Tuberculosis of the spine. Okay, so tuberculosis spine, why this topic is important? Because it has been seen that tuberculosis of the spine is a very important cause of morbidity, and sometimes it can become even a cause of mortality, particularly when the tuberculosis is multi-drug resistant or MDR tuberculosis, which can also happen nowadays. And this tuberculosis or tubercular osteomyelitis or vertebral osteomyelitis or spinal osteomyelitis due to tuberculosis, also known as Pott's disease or Pott's spine, can lead to devastating paralysis due to the damage to the spinal cord because of the compression, either by pus or by bony elements, whether it is in acute stage, subacute stage, during treatment, or after completion of medications. So this can have devastating manifestation, which is known as Pott's paraplegia. Okay, so TB spine is a very important cause of disease, morbidity, sometimes mortality as well. It can also lead to paralysis of bladder and bowel and permanent damage to the control of the neural control of the urinary bladder, leading to neurogenic bladder, right? There may be different causes of neurogenic bladder. Now, if you see, the disease burden of tuberculosis has not decreased. In fact, it has increased in certain situations, like when there is HIV infection, they are more prone to tuberculosis, right? Now we are also talking about COVID leading to tuberculosis because of use of steroid. So, and there is also emergence of drug-resistant strains of Mycobacterium tuberculosis. As I mentioned, there can be multi-drug resistance, or there can be extremely drug-resistant or XDR tuberculosis. These are new challenges ahead. We know tuberculosis was recorded since time in the history in Egypt, in the pyramid, in the mummies also there is evidence of tuberculosis centuries and thousands of years ago, and still this mycobacteria surviving and becoming more lethal in the form of multi-drug resistant and extremely drug resistant tuberculosis. Now, why it is still thriving in India? Because still we are socio-economically not advanced. There are a lot of disadvantaged people who are easily getting infected. Our public health policies are not great. People probably for the first time we are wearing masks. Because of COVID, we don't wear masks for tuberculosis. Resource constrained areas like Northeast where even less resources in the health sector. So there is less follow-up of pulmonary tuberculosis giving infection. So TB is a huge socio-economic and public health burden. TB spine is most common type of bone tuberculosis or skeletal tuberculosis, which will have devastating manifestation as we manifest later. Now, this is a relatively common form of extrapulmonary tuberculosis. This is known as Pott's. Tuberculosis spine. He was also talking about occupational health. If you remember this chimney sweeper's cancer, he was first described at Pott's. TB spine is a form of spinal osteomyelitis. It is basically a bony osteomyelitis involving the intervertebral disc also secondarily. Most commonly, it affects the anterior structure of the vertebral column and the end plates. If you see the normal spinal column on A, you can see the vertebral body, the nicely spaced intervertebral disc, the spinal cord behind. And tuberculosis is shown in B, infection of the peridiscal region or cartilage end plates. And infection of the intervertebral disc eventually happens because the blood supply to the disc does not come directly, it comes from the bone. As the bones are getting infected, the disc also gets digested. They secondarily die, they undergo disintegration because of further devascularization. So infection now spreads, causes discitis. This is a very important terminology that you have to remember. In MRI, It is shown as spondylodiscitis, which is almost pathognomonic of tuberculosis. Okay, discitis. This is secondary destruction of the intervertebral disc. The nucleus pulposus is damaged because there is less and less blood supply. Also, infection was released enzymes and other things. Spondylodiscitis will secondarily lead to collapse because it is very, very bone, so it will start collapsing anteriorly, leading to kyphosis. And then the bony prominence behind will become even more prominent, forming a kyphus. And the green one that you can see here is the formation of pus. A tubercular pus will be formed. Okay, so this will, as it becomes bigger, it can travel to another area. It is known as cold abscess. These are important things to understand. So in the step one, the bacilli will come from a primary focus, say from the lung. It will reach the bloodstream. From the bloodstream, it will reach the vertebral disc space. In the first stage, in the second stage, once infected, the soft nucleus pulposus, they will weaken, decay, and the bones start degenerating. This causes the disc to close, squeeze down, and the nerve root will cause pressure. The infection spreads to vertebral bodies above and below the disc. There will be at least 2 vertebrae are often involved. It is also related to the embryonic blood supply. The same blood vessel supplies both the vertebrae, one above and one below. That's why 2 vertebrae are usually involved because of the unique embryological blood supply of the sclerotome, myotome, and the notochord, that from where the spinal cord develops. Stage 4, the bone becomes obviously weakened by the infection. It collapses under the weight of the human body, on the upper part of the body. The weight of the upper part collapses the bone. It's become weak. The deformed spinal column now compresses the spinal cord as well as the nerve root behind, as you can see, shown here as the red. And there is a formation of internal gibbus. You can see this is the internal gibbus. This bone will become prominent behind. It is external gibbus, which you can clinically feel the gibbus or the prominence. And here there is an internal gibbus, which will become clear when you do MRI. Okay, in the sagittal section, you can see nicely. Now, over the time, the deformed vertebra will try to heal, whether you treat it with medication or sometimes even when patient's own body mechanism will try to heal, and then they try to fuse 2 vertebrae will try to become 1 vertebra. This may further compress. However, this may further compress the nerve root and causes pain and neural deficit and paraplegia. Now, the commonest mechanism affecting spinal cord function is the extradural compression, as I said, because of pus, because of granulation tissue, because of caseous material that are typically formed in tuberculosis. They will compress here. Okay, this is the internal kind of pus, gibbus, kyphus forming here. There are 3 vertebrae involved in these things. You can see the compression of the spinal cord here in this MRI in T2 view. Now, there is sequestration of the disc. There is internal gibbus formation. There is pathological dislocation also can happen later, as we will see later. Dura is not directly involved. There is cicatrization or scar formation, which is peridural fibrosis. There will be fibrosis because of inflammation will lead to fibrosis. In tuberculosis, we know there is a lot of fibrosis because of cobweb coagulum formation, you know, in pathology. There is poor recovery despite surgical decompression. All these things stays for a longer period. And the patient is not taking treatment properly, not taking the medicine properly. There is defaulting of the tubercular medicine, or the patient is still walking when there is a compression, can lead to poor prognosis despite surgery. So vertebra will collapse. You can see the anterior height of the vertebra, normal, in between 1 vertebra. Here it is shown 1 vertebra, normally in TV 2 vertebrae will be like this. So there is collapse, anterior height will decrease. This is typical, you know, the appearance of the collapsed vertebra. You see the above vertebra, below vertebra, you see the in between vertebra has collapsed, right? The posterior part has not collapsed as yet. Okay, so this is the kyphotic angle measurement. We measure Cobb's angle like this. Draw a line from the superior articular surface, that is end plate, superior end plate, then inferior end plate of the lower vertebra, then pass perpendicular and see the angle how much it is. Okay, this is one direct method of measuring the same thing. So here in clinical, you can see the kyphus, the external kyphus or clinical kyphus. You can see here in this D1011 patient, tuberculosis patient. Here you can see the collapse of the bone happening, the discitis, which is appearing white because of inflammation of collection of fluid, like the CSF here. This is T2 image of MRI. So this deformity or kyphus, then if there's a single vertebra is prominent posteriorly because of the spinous processes here, you can feel easily. It is called knuckle. If 2 or 3 vertebral spinous processes fail, it is called gibbus. If it is more than 3 vertebrae, it is known as angular kyphus. It is known as rounded kyphus. So it is not angular, it is rounded kyphus. It will become smoothly rounded, not very prominent. So here it can happen in cervical spine. Here you can see in the cervical spine there is cord compression. There is a vertebral pus formation here also, colepsis. This is the parapharyngeal abscess, which can lead to hoarseness or voice, respiratory depression also. Okay, this is happening just behind the esophagus. Okay, so internal gibbus retropharyngeal colepsis can form. Now, this will lead to pathological collapse of the vertebra, lead to spinal cord compression, with nerve compression, colepsis formation, as I said. So there are basically 5 types of tuberculosis, out of which the most common type is the paradiscal type or anterior type, which is this one that we have just seen. Then there can be a rare venous type, which can be central tuberculosis. It comes through the vein rather than the artery that we have seen in paradiscal. Then rarely there can be only anterior. Sometimes it happens only anteriorly below this anterior longitudinal ligament. Okay. Then appendicular. Appendicular means the appendages of the vertebra, just like pedicle, the spinous process, the lamina, the etc. They are known as appendicular because it happens in the appendix of the spine. Then articular or synovial type, which can happen here in facial joint, which is even more rare. Okay, so the first 2 are more common, and this central type sometimes can collapse to single vertebra. So this is one area where only one vertebra may be involved in central type. Otherwise, it usually involves multiple vertebrae. This is a kind of pathology. Now, this paravertebral abscess that is formed, the spine can travel along the path of least resistance, like through the muscle plant, through the artery, around the artery it can travel because the artery is pulsating, it will be easy for the pus to move along the pulsating artery. Okay, so that is the path of least resistance. So granuloma formation, tissue necrosis, inflammation, pus, they will trek along the tissue planes, adjacent vertebral body, under the longitudinal ligament, along the facial plane, and then they will travel far and wide, like in psoas sepsis. It can travel from lumbar spine to the psoas muscle and might appear anywhere in the groin. Okay. Or it might go behind to the, in the abdomen, in the petit triangle, so on and so forth. So colepsis is called colepsis because it travels from the actual site of the infection where there is a lot of inflammation, and it appears somewhere else below normal skin, so you will think there is no inflammation. That's why it is called colepsis, because it is away from the war zone. Okay, like it's a dead body coming from, in Kargil to Assam, so you don't feel the heat of the actual, Kargil. So that's why it is colepsis. So colepsis looks like this: granulation tissue, pus, just like this, and the skin is normal because it is appearing far away from the actual site of disease. It can happen like this, that spinal tuberculosis, thoracic spine can go in a lady like a breast abscess. Okay, so actual disease is here, but it appearing there through the trekking through the nerve around the perineural tissue. So what are the symptoms? There may be constitutive symptoms like malaise, weight loss, night sweat, evening rise of temperature. These are the 4 important symptoms that we have to remember. Specific symptoms may be night cries, more common in children. They will cry at night. Okay, there will be stiffness, deformity, kyphus, knuckle, rounded kyphosis, as I told you, restricted range of motion due to severe spasm and pain, enlarged lymph node may be there. You might feel generalized lymphadenopathy also. You might feel an abscess, cold abscess in the abdomen, in the petit triangle, in the groin, in the thigh, in the back itself, or there may be neurological deficit because of POTS, paraparesis, or paraplegia in the active stage of the disease. So general symptoms on the left side, it depends on which area. If cervical spine, it can be dysphagia, hoarseness, respiratory stridor, stiffness, retropharyngeal abscess formation, supraclavicular fossa abscess, quadriparesis, etc. If it is thoracic spine, mostly you'll get POTS, paraparesis, paraplegia, kyphosis, and all the general symptoms. If it is lumbar spine, symptoms may be less, and there may be, some kind of paraparesis, iliac fossa abscess, or gluteal abscess. All depends on the location. The presentation might differ, but general symptoms will remain more or less the same. And sometimes this may not be there. You might also get signs of HIV if the patient is having HIV and tuberculosis co-infection. So you must be mindful of patients on steroid, on HIV, on immunocompromised status. You must suspect them more. And in malnourished patient, weight loss patient, patient from lower socioeconomic group, you must have high index of suspicion. In paraplegia, you will get symptoms like weakness, paraparesis, paresthesia, numbness, disturbance of bladder control, urine. Now you have to ask for all these things. Refluxes might increase. There may be upper motor neuroscience if it is compression is upper motor. There will be clonus in paraplegia. Okay. So pain may again differ in cervical root. It can be arm pain, in dorsal spine. It will be somewhere in the girdle or pectoral pain. In dorsal lumbar, it will be abdominal pain. They might present as abdominal pain. Lumbar root, it will be groin pain, or lumbosacral spine. It can be sciatic type of symptoms. So it will absolutely depend on the location of the tuberculosis. Spinal stiffness, night cries, deformity, cold abscess, as I said, paraplegia, if neglected in early stage, it will lead to paraplegia. It can lead to severe deformity. This is not a very classical of spine tuberculosis, but these are very classical findings of tuberculosis. Scoliosis is not common. So what you get, clinical features in examination, you will find kyphosis, the great number of features. Palpable cold abscess, you will get around 20%. If you are more careful, you might get more. You have to palpate abdomen, examine the patient, undress the patient, see from behind, see from side, palpate, use ultrasonography to find out any abscess if required. Radiological paravertical abscess will be detected in more number if you do ultrasound, or also in X-ray. Neurological involvement, tubercular sinus formation you might get, but not very common. Associated extraspinal skeletal focus in other joints like hip joint, knee joint are also sometimes found in 10% of cases. Then renal tuberculosis, abdominal tuberculosis, particularly tubercular abdominal lymphadenopathy or generalized lymphadenopathy or tubercular lymphadenopathy, not uncommon. So if you see, the most of the cases happen in the dorsal-lumbar spine, around 42%, that involve the thoracic, thoracolumbar region. Okay, the most mobile part, which is more injured, more mobile part of the spine, are usually more affected. There are reasons. People say that it is close to the abdomen, it is close to the renal site, okay, and it is getting more injured, so it is more mobile part, that's why it gets affected more easily. Next is the lumbar spine, then cervical spine. So the dorsal spine, although shown as 42%, I would call it dorsal lumbar and the dorsal combined is the highest, out of which it is theoretically dorsal lumbar spine, which itself being a lesser number, just few vertebrae, still their incidence is higher. So diagnosis, now you will make a diagnosis based on all these signs, symptoms, the exposure history of contact with tuberculosis, and all these classical sign symptoms that you might get. ESR may be raised, hemoglobin may be low, X-ray of the spine and the chest X-ray, okay, might tell you of the focus of primary as well as show the disease itself. Ultrasound will tell you the abscess formation, the cold abscess you might easily detect. CT and MRI scan will tell you the disease, the site of the disease, the extent of the disease, the amount, the internal internal gibbous, that is formed, and the past formation and how they are traveling. All these things may be easy for you to see in MRI. MRI will tell you the pathognomonic spondylodiscitis, which is very important. Don't forget this. Immunological tests you can do, like MON2 test. If it is strongly positive, it might be very important. But more important, if it is negative, then you should think of other differential diagnosis, like histoplasmosis, brucellosis, and also remember the metastasis in the spine might look similar to tuberculosis in elderly patient in particular. So these are differential diagnoses. So MON2 still negative, you have to think about other things as well. Then microbiological tests are important because to see the tubercular mycobacteria with a biopsy will be great. Nowadays we do gene explant. We take out the pus. Often we request the radiologist to take an ultrasound guided or CT guided aspiration of the cold abscess or the paravertebral abscess, what we call sometimes bird's nest abscess, okay, to aspirate. And we send them for a gene expert the DNA analysis, CVNet. I'm sure you know what is CVNet, country-based test, amplification of the deoxyribonucleic acid of the mycobacteria. So CVNet. We also do drug resistance studies, very important because as I said, when you take a sample, if you see the bacteria, mycobacteria, it is always prudent, it is wise to do a drug resistance test because you never know, some of them might come out as drug resistant, and if you don't treat them in time, they will develop POTS paraplegia and they may not recover, and their treatment has to be the second line medicine. So sample shows classical TB history were associated with a positive culture in only 23% cases. Only 2 specimens stained positive for AFB of the 50% positive culture, and 12% were multi-drug resistant. All drug sensitivities were confirmed with PCR. This is one of the studies that we have done here in Nigrin's, where we found that it is important. Only 23% you might get the mycobacteria. So it is important that that we go for gene expert or molecular diagnostic tests rather than just going for culture. This is what I want to highlight. So how do you treat them? The most important treatment is giving rest to the patient, explaining the patient what has happened, telling the patient the importance of compliance to treatment, compliance to bed rest, compliance to the spinal brace that you are going to give when it is recommended. So drugs form the mainstay of treatment because we know there is a cause, we can treat it. We must rule out drug-resistant tuberculosis from the very first time. That is the ideal way. If that is the true, we have to immediately go for second-line drug. Bed rest is very important because if the patient keeps walking, there may be collapse of the vertebra, and patient without neurological deficit might develop paraplegia. Spinal brace can be given, but spinal brace has to be given. The right type of brace has to be given. If you give a wrong brace, it will give you a false security, which is not good. Okay, so usually often we give tailored spinal brace and it has to be well fitted. Patient has to be comfortable with it. It has to be sometimes custom made for the patient for tolerability. So we know all these drugs, we know all this dosing pattern. Please, if you don't remember, please remember today. Please write it down. The per milligram body weight wise, so that you can treat children as well. Now, this is the policy of DOTS. I'm sure you know all these things from medicine. I'm not going into detail of this. Failure of conservative treatment can happen when there is drug resistance, you have not tested for it. When there is inappropriate treatment, your drug they are not taking properly. When there is multi-drug resistant tuberculosis, when there is immunosuppression in the patient like HIV, diabetes, patient is on steroid or something, so they might fail to conservative treatment. So there is a active early stage disease on the left side, active advanced stage, and healed stage. Okay, depending on that. But what we have seen here is that all of them must get chemotherapy because that is the mainstay of treatment. But despite chemotherapy, there may be neurological deficit, and the neurological deficit patient, particularly when on tuberculosis medicine also they develop neurological deficit, or they don't improve, then we might have to go for surgery. Often you go for posterior instrumentation, means we go posteriorly, we release as much as we release the pus, we remove the compressive elements like the gibbous, internal gibbous, or the granulation tissue, pus, etc. We decompress the spinal cord and we give stability by fixing with rod and screw there, so that there is pain relief, and we create an environment for stability of the spine as well as conducive environment for healing. So in case of healed disease, there can be a late POTS paraplegia, which happens because of the internal gibbous not being released in the first place, and this may require complete removal of the vertebra and reconstruction and deformity correction, which is very risky operation, but sometimes it is required. So simple surgery that is sometimes done when patient does not respond to ATT is costotransversectomy. Remove the transverse process, remove part of the rib, and pus will automatically come out and patient will recover. Just remember here, you have to be careful. We might have to excise the one rib or two rib to get access to this. You have to be mindful of the artery, which will be coming the branch of the aorta, the spinal artery. It might bleed heavily, so you have to be careful and ligate it. And you have aorta in front, you have to be mindful when dissecting. There may be spine at risk sign, where in children, this is described by Raja Sekharan from Coimbatore, our president of Indian Orthopedic Association, and also president of the Indian Spine Society. So he has shown that when more than 2 vertebrae involved in children, this facet joint behind in the spine is dislocated, and this might lead to severe deformity. Okay, so this is a spine at risk sign, and there can be, this is beyond the scope of discussion, but this is one important sign being described in children, which we have to be mindful while treating children. So this is how we fix with multiple rod and screw, decompress the spine, release the pus, align the spine when possible without risking the spinal cord, fix it, regain the alignment, decompress the spinal cord. This is how we put the pedicular screw through the spinal pedicle, mindful of the spinal cord, don't enter here. Okay, be mindful of the aorta, don't injure that, and fix it with pedicular screw rod system. Try to align the rod, give the alignment. This is how the entry point, just on the side of the facet joint on both sides. So this is enterolateral decompression, a very common decompression that is required when surgery is indicated, patient not responding, patient in severe paralysis in the first place, patient deteriorating on tuberculosis medicine. Then what do? We remove the posterior appendages, the spinal processes, the pedicle on one side, then the rib on one side, and even part of the vertebral body anterior to the spinal cord. So that is why it is called enterolateral decompression, because you remove the anterolateral side of the spinal cord. The spinal cord is here, this is enterolateral to the spinal cord. So, but actually you remove posterior also, okay? But only on one side facet you try to preserve, because you want to preserve the stability. So this is what you remove, the transverse process, the rib, the anterior lateral part of the spinal cord on one side. Usually you go for left side, you don't go right side, because you have the vena cava. We don't want to injure the thin wall vena cava. If they bleed, patient might die on the operating table. So you go from the left side where the aorta is there, which is thick wall. It is difficult to injure it, and even if it is injured, it is possible still to repair it. But I never want to injure it. Of course, patient might still die. So the management summary is TB spine is an advanced disease in itself by definition. So once you die, disease. It requires taking contact history, clinical examination, radiological examination, bacteriological examination, histological examination, where pathology and bacteria is not found, molecular diagnostic, including for multi-drug resistance drug, tuberculosis by CBNet, the gene expert, the TrueNet or CBNet, and rapid tests. It requires long-term aggressive systemic antibacterial therapy. Usually give it for 18 months, 1.5 years. You must do liver function tests, ESR examination and follow-up. It may require prolonged bed rest and immobilization. It may require surgical intervention for neurological decompression in paraplegia, paraparesis. So this is the summary of the treatment. So this is what I had all for you. So if you have any queries, you can ask me.